Kia ora katoa. Welcome along everyone to the University of Otago online masterclass in public health. I'm Simon Horsburgh. I'm from the Department of Preventive and Social Medicine down in Dunedin, and it's my pleasure to be the MC for this online masterclass. We've got a great selection of presenters today talking about a wide range of topics across the spectrum of public health, and I think this is a great opportunity to see some of the diversity of the things that we do in public health. The format of this webinar is that we have a presentation from each of our presenters lasting around 10 to 15 minutes. During that time, you're welcome to submit questions into the Q&A that should be at the bottom of your screen there, that we'll give to our presenters at the end of the session. So if you're putting in a question there, please write in your who that question is going to be addressed to, which of our speakers you want to answer it, so that I can put it on to the right person. So we'll have each speaker for 10 to 15 minutes, and then at the end we'll have the Q&A session, which hopefully we'll have about 5 to 10 minutes for that. Also, just to let you know that this session will be recorded, and you'll be sent, if you've registered, then you'll be sent a link to the recording to look at after the session. Okay, and with that, I'd like to introduce our first speaker, who is Rose Crossin, a senior lecturer in the Department of Public Health at our Christchurch campus, and she's going to present on what would a public health approach to methamphetamine look like in practice. So thank you very much, Rose.
Cool. Thanks, everyone. So today we're going to be starting off by talking about methamphetamine. So just to ground us all, methamphetamine is a strong stimulant drug. You will sometimes hear it called P or ice, and this is methamphetamine in its crystal form, but it can also come as a powder. The drug is able to be swallowed, but it is typically smoked or injected. And when people use methamphetamine, it can induce feelings of euphoria and energy and alertness, but on the negative side, can also bring on feelings of paranoia, aggression, and hyperactivity. And the effects can be quite long-lasting, anywhere between 4 to 12 hours, depending on the dose and on the person. So I guess the key message really is there's really quite a lot of methamphetamine in New Zealand. So in the last 12 months, customs have seized almost 3,000 kilos, but nevertheless, prices of meth continue to decline in New Zealand. And if we believe the laws of supply and demand, that would suggest to us that there is still a high supply despite all of these seizures. Wastewater testing tells us how much methamphetamine is being used in particular regions. In the first quarter of 2024, there was an average of almost 18 kilos per week of methamphetamine used in New Zealand, but that's not equitably distributed. So there are really stark geographic differences in the way in which methamphetamine is used. And the New Zealand Health Survey data tells us that just over 1% of people aged 15 or over in New Zealand report having used methamphetamine in the last 12 months. And so that works out to about 50,000 people. And again, there are some demographic differences, with men more likely to use methamphetamine than women, and people with disabilities more likely to report using methamphetamine than those without. So methamphetamine is a Class A drug under the Misuse of Drugs Act. Getting caught with methamphetamine for personal use, so possession, can have a penalty of up to 6 months imprisonment or a fine, and supply or manufacture can result in life imprisonment. It's also important to note that the utensils used are also illegal. So this is things like the pipes used for smoking methamphetamine. And in New Zealand, about half of all of our drug offences are related to methamphetamine. In 2020-21, there were almost 2,000 convictions for low-level offences. So this is possession of the drug or possession of utensils. And this is still occurring despite the fact that we have what is called the discretion amendment in our Misuse of Drugs Act, which says that police can charge someone with possession or with low-level drug offences if it is required in the public interest. So in almost 2,000 cases in that year, the police decided it was in the public interest to have a criminal penalty for possession or utensil possession. What that works out to then is for methamphetamine is that it's about 50-50. If someone is caught for low-level offences like possession, it's basically 50-50 as to whether or not there'll be prosecution or whether or not there'll be an alternative justice response. So quite a high burden coming through our justice system. The National Drug Intelligence Bureau estimates that methamphetamine harm costs New Zealand about $864 million per year. And we need to think about harm in a way that is beyond just the effects of the drug itself. And a useful way of thinking about harm is to start with harms to self. So this is harms to the person using the drug. This can include medical consequences, psychological harm, addiction or dependence, the loss of relationships, tangible losses through potentially losing a job or being imprisoned or loss of finances. So these are harms that are to the person who is using the drug. But it's also really important that we think about harms to others. And this isn't just the people who are around the person using the drug, their whānau, their friends, their family, but it is also about wider societal harm. And the harms to from methamphetamine are again really diverse. This could be things like injury, perhaps. There is a car crash and the person driving was affected by methamphetamine, but other people were injured. There are crime impacts. So obviously because it's a Class A drug, it is a black market supply. So there is crime associated with methamphetamine supply and manufacture. There is economic cost to our health system, to our justice system, to policing, to community services, harm occurring to family and through loss of relationships or family disruption, and really just damage to communities and the way in which communities break down and can break down when a lot of people in that community are using methamphetamine. And this is from a study that I published last year now, which is a way of objectively looking at harm, taking that broad definition of harm. And when we look at all of a big list of drugs across New Zealand, both legal and illegal, you can see that methamphetamine sits at number 2. So it's the second most harmful drug in New Zealand after alcohol. The harm is roughly 50-50 between harms to self and harms to others. And it is the most harmful of the illegal drugs in New Zealand. But it's really important to think about harm and where harm comes from. So some of those harms that we talked about before are harms that occur from using the drug itself. So, from using methamphetamine can result in cardiac problems, so a direct harm arising from the drug. But there are also drug policy harms, and some of these harms are created by the fact that we are in a prohibition environment. And this is a really famous diagram in drug policy circles. And what it tells us is that harm is high at both ends of the spectrum. Harm is high when we have commercial promotion of a drug, say for instance, like alcohol. Harm is also high when we're in an ultra-prohibition kind of environment, and that's where we are with methamphetamine and other illegal drugs in New Zealand. And what we've managed to do is miss the mark both times, where strict legal regulation results in lower harm, and we've managed to overshoot it at both sides. So our national drug policy tells us that minimising harm is really important. It doesn't actually mention the word use. It tells us that the focus should be on minimising harm, but the Misuse of Drugs Act is very much focused on preventing use as a way of preventing harm. In drug policy, we often talk about the 3 pillars. So we have supply reduction. So this is things that are used to try and stop a drug from being present. So this might be customs, policing, prisons, seizures effectively. Demand reduction, and this includes drug treatment, so for people who are using a drug and who are trying to stop, but it also includes preventative measures, so things that stop people from initiating drug use, and harm reduction. And this is how programs that are intended to reduce harm without necessarily requiring abstinence. So those are the three pillars. In practice, however, what we really have is something that looks a little bit more like this, where supply reduction gets the focus of our drug policy and all of its resources, demand reduction gets less, and harm reduction gets very little at all. However, what evidence, we should really ask ourselves, if we're interested in evidence-based policy making, what evidence do we have that this current approach to drug policy is working? And the answer is there is very little. So the UNODC tells us that global supply of methamphetamine is near its highest point on record. So there were 367 tonnes globally seized in 2022. This graph is of seizures globally at the bottom, and the most recent year of data is the third highest global supply on record. Data at both population and individual level tells us that criminal penalties has no deterrent effect on people using the drug, and that countries with stringent drug policies do not have lower levels of use than countries with liberal ones. And the Global Commission on Drug Policy came out famously quite recently and basically said prohibition has failed to achieve its goals whilst also resulting in harm. So that's supply reduction not working. If we think about demand reduction, so particularly treatment, we have no effective pharmacological treatments, and the evidence for efficacy of the sort of psychosocial treatments for methamphetamine is relatively mixed. There is no there is no kind of gold standard of treatment for methamphetamine dependence or methamphetamine harm. So supply reduction isn't working. Demand reduction has mixed evidence. That's, however, where we're putting our money. So I beg the question then, if most of what we're doing isn't working, and in some cases may actually be increasing harm, we have to ask them, why do we keep doing it? And what are our alternatives? So the alternative is to take a public health approach. And there's been some really great work coming out recently, particularly from Canada, about defining what a public health approach means in practice. And it would include harm reduction, it would include regulation, it takes into account the determinants of health, it encompasses treatment, it encompasses prevention, and importantly, it also includes stigma reduction. However, what it does not include is a criminal justice approach to drugs. So what could this look like in New Zealand? There was, I was part of an awesome team a couple of years ago in collaboration with the Helen Clark Foundation and the New Zealand Drug Foundation. We published this report called Minimising the Harms from Methamphetamine, and we proposed different models for how we could actually reduce harm from meth in New Zealand. The first thing we need to look at is our drug laws. Absolutely, decriminalisation would be a step in the right direction, but that does not change anything about the fundamental drug supply or buying drugs out of a black market. So we can look towards models of sensible public health regulation. And there's an excellent book published from the UK from the Transform Drug Policy Foundation that gives us a blueprint to do this. We need to expand and fund programs like Te Ara Oranga, which was a Northland program that tried to take a more holistic view of reducing methamphetamine harm that encompassed people's overall hora and well-being, and looked at the ways in which people could be supported to reduce their methamphetamine use. We also need to look for low barrier treatment services and better funding of harm reduction. Harm reduction itself is an interesting concept because what it refers to is all of the policies and programs that aim to minimise the consequences, the harm of drug use, without actually requiring abstinence. It is grounded in human rights, and all of its criteria for success are about quality of life and well-being and the provision of non-judgmental, non-coercive services that incorporates and empowers the voices of people who use drugs. Basically, harm reduction services are about meeting people where they're at. This could include things that we already have but could be expanded, like needle exchange programs, like drug checking, like safer drug use information. But we can also look to international examples of how we could expand our harm reduction offerings to include supervised consumption facilities, safer smoking kits, and safer supply to try and reduce harm as part of our overall drug policy response. But to do that, we're going to have to overcome some really big barriers. partly due really centred around stigma reduction. And the way in which we do that is we need to engage with people who have got lived and living experience of methamphetamine use and harm, build partnerships, engage in dialogue, bring both evidence and values to bear, and advocate for political courage and for political change. But in doing that, we actually have to overcome some big barriers in ourselves, because we all have this kind of war on drugs history that is embedded within our psyche, and to be able to effectively reduce methamphetamine harm using a public health approach, we have to challenge our own narratives and our own understandings about methamphetamine and the people who use it. Thank you.
Kia ora, Rose. That was really, really interesting. Thank you so much for that presentation. If anyone, we've got a couple of questions in the Q&A, but if you've got any questions at all, again, don't hesitate to throw them into the Q&A there, and just put Rose's name on it so we know who to put it towards there. But we'll address questions at the end of the seminar. Our next speaker is all the way from Wellington, in the virtual world, and is a senior lecturer at in public health at the Department of Public Health on our Wellington campus. It's Jeannine Stairmand, and she's going to be presenting on Titiro Whakarongo Kōrero, the development of a supportive care needs assessment tool for whānau Māori experiencing cancer. So, thank you, Jeannine.
Tēnā koutou, tēnā koutou, tēnā koutou katoa. He mihi mahana tēnei ki a koutou I tēnei wā, Māori ora. Tuatahi, first of all, I'd like to mihi to the Te Māori whānau and whānau participants in our study. I'm doing this up front just in case we get short on time at the end. Also want to mihi to the study advisory group and the research team, in particular Tira Albert from Manawahine Te Māori, Bridget Robson and Dr. Virginia Signal here at the University of Otago in Wellington. And also acknowledge that the study to develop this tool was funded by the University of Otago Research Grant. Ko wai au, e te taho tōku pāpā, he kurangi te maunga waiapu te awa Ngāti Porou te iwi, I te taho tōku māma, hurai, te mana Pākehā ngā iwi, ko Jeannine Stairmand tōku ingoa. So kia ora everybody, my name's Jeannine Stairmand. As has been introduced, I'm a senior lecturer here in the Erupo Māori Centre, Department of Public Health in Porou, Wellington. I grew up here in on the lands of Ngāti Rangatira out in the Porou area, and have worked in the health sector all of my life. Like many of you, no doubt, online, I'm a mum, sister, auntie, and have been touched more times than I'd like by cancer. So thank you for joining us today and listening to my presentation about our study to develop a supportive care needs assessment tool, particularly for whānau Māori. So just a bit of background or whakapapa on the project. As everybody knows, cancer and chronic conditions has a massive impact on people, and that we know that there are inequities in, for example, survival inequities in some cancers, and some of the reasons we know for those are things like screening programs not reaching Māori the same, maybe there's advanced disease at diagnosis, maybe high rates of comorbidity. There might be things like lower or less optimal access to cancer care, and for reasons perhaps related to things like racism, the design of our health system, all those kind of big ticket items. So when it comes to the person in the whānau, though, assessment tools can be useful to help figure out what their needs are and what can be done to help them while they're on that path. We do know that supportive care needs for whānau Māori, our knowledge of that is growing, but it's still limited. It can't be assumed, and it may be different for different people and may change over time. We also know that our Indigenous whānau over in Australia, Gail Garvey and co have been successful in developing a supportive care needs assessment tool for Indigenous Australians. So the whāriki, or the mat, I guess, for that has been laid. And through a prior study we did with some whānau Māori, the need for some type of assessment was identified in that study called Waharua Kōpito. Right, so that's the background to why this study was undertaken. So the methodology we embraced with our study was to take a kaupapa Māori approach, informed by te tiriti o waitangi, and particularly looking towards Māori rights to health and health equity. Kaupapa Māori, informed by Graham Smith work, so Māori ways of doing things, customs led by Māori, and guided by Māori principles like ka nohi kitea, face-to-face, manaaki ki te tangata, share and host people and be generous. Those kind of principles underpin the study. We also sought expert advice. So Gail Garvey, who I just mentioned before, was an advisor to the study. Also Dr. Nina Scott, which many people who work in the cancer space will no doubt be aware of, and community representatives like Cheryl Davies from Tuputahi out in the Hutt Valley here. So the objective of our study was to develop a Māori-specific supportive care needs assessment tool by Māori, by modifying, an existing supportive care needs assessment tool. So similar to our Australian colleagues, we worked with the SF34, the supportive care needs survey short form. So 34 questions were contained within that survey. That was our starting point. We undertook some processes to modify that, which I'll talk about next. And we also wanted to get stakeholder perceptions of how tools might be optimally integrated into practice. So stakeholders consisted of kaiawhina, kaimahi, cancer nurse specialists working in the cancer spaces. So a little bit about who we included in our study. So we looked for a diverse range of people from different iwi, urban, rural, ages and stages in their treatment or cancer pathway. So some may have been survivors, for instance. We focused on adults, so 18 or older, who had received a cancer diagnosis and who were well enough to participate. Recruitment occurred primarily with the support of Te Māori, which is a Māori cancer support program based here in the Hutt Valley. Networks with Māori providers, DHB, the hospitals, cancer networks, and the Cancer Society. So stage one, we had 3 stages to our study. Stage one, we undertook semi-structured interviews with Māori whānau and stakeholders in focus groups, and looked at the SF34 in particular and identified things that people liked or didn't like. Then we looked for concordance or discordance between the whānau interviews and the stakeholders, and developed version 1 of our tool. We then took that out in stage 2 to help us refine that, again with a separate, a different group of whānau Māori who had received a cancer diagnosis, but the same stakeholders. And then we took the feedback from that to develop our second version of the tool, and then we took that back to the stakeholder group again for a final refinement, and also to develop up some instructions for people who might use the tool. I will just put these up because the study was undertaken during COVID, so like many studies, it took a bit longer than we would have liked or than we initially planned, and so a couple of our Zooms with stakeholders, a couple of our hui with stakeholders were undertaken via Zoom because we were in different lockdowns, of course. All right, so to give you an example of some of the feedback we got through our different stages, question 1 was around pain, and there was concordance between kaimahi and whānau around the importance of pain being included, that it might change for people throughout their journey, and it was important to keep it near the top and to ensure at the visit when the assessment was being undertaken that people's pain, that they weren't in pain or that their pain was being managed or in control. And there was also recommendations around wording of some of those questions. Questions 6, 7 and 8 in that hinengaro space, particularly mental health. Whānau felt those words made it sound very serious, and of course they are, but saw that it was potentially leading towards a diagnosis, and they thought these kinds of feelings would be normal actually as part of going through the process of receiving a cancer diagnosis. And Kaimahi also thought that whānau wouldn't like necessarily things to be spoken about in such a way, so encouraged us to merge those questions or that kaupapa, if you like, together in the development of our tool. So in our tool, we developed 8 questions over 8 domains. I'll just pause a second to let you run your eyes through those. I will say we drew off obvious Māori models of health like Whare Tapawhā and the Meihana model. There's 2 that come obviously to mind there. Just move to our next slide. So stakeholder perceptions of how to integrate such a tool was to be mindful of the scope of practice of the person who is using it. So there could be social workers, nurses, kaiawhina, all sorts of people might be able to use such a tool, that it was important to take a relational practice approach, so kanohi ki te kanohi, to have a ngāwari style about the person, so gentle, kind, flexible, and that Titiro Whakarongo Kōrero, which we ended up adopting as the name of the tool. So for the people administering the assessment to be using the range of senses they have rather than just a question. That the people who are using the tools had knowledge of te ao Māori and were able to pronounce the Māori words that were being used in the tool, and that of course they were all over support resources that were available in their community, that take a mana enhancing approach, but also on a practical level mindful of IT systems because they're such varying across the country. There was also a request for oral and visual approaches to be taken with the assessment. Here's an example of how the tool might be used. So once the need's been identified, then an action plan would be developed. There's a prioritisation scale you'll see on the left there. So critical emergency might be something requiring someone to call an ambulance straight away. Maybe the person's actually in quite a lot of distress or unwell, right through to something minor, like maybe the lawns are long and they need to be mowed, but it's not a high priority in this very short space of time. We also, in line with the desire for mana motuhake, or that self-empowerment approach as well, 3 action levels. So what could the whānau, the person, be doing? What could the actual broader whānau be doing? Maybe they could help mow the lawns, for instance. And what could services do? Could it be a referral through to WINS for support if needed, as an example there? So there's some points of difference for the tool that we developed. So obviously, as I've mentioned, we drew off Māori models of health. It's more of a community-focused assessment tool. The SF34 lends itself more to be used in the clinical setting in a hospital space. I won't read through them all. I will just mention Te Reo Māori there, given that's been quite topical in the news in the last couple of days, is for Te Reo Māori to be used to open the space. So maybe kia ora might be how it's opened, and to take a participant-led or reflective use of te reo from there on out. One thing we did do was wanted to make sure that comorbidities were included in our tool, given the number of Māori whānau who do have multimorbidity, and also addition or grouping of what we call pātai pāwera sensitive topics. So that might be around sexual health and those types of topics. Where to next? So we are in the highlighted area here, testing the tool, acceptability and feasibility. With the support of the New Zealand Cancer Society, we've received funding to undertake that next step for this tool. Thank you, Cancer Society. And ngā mihi, that is me for this session. Kia ora.
Kia ora, and thank you so much for that presentation. It was really, really interesting and I think very important work. And thank you to everyone who is providing the reactions there. It's really lovely to get the response from the audience through your claps and hearts and thumbs and Venezuela's. I'm going to move on now to our next speaker and just remind people that there's the Q&A session at the end of the presentations where we'll address the questions you've given to us in the Q&A. So keep them coming in and make sure you tag who it's for. Now, our next presenter is Richard Egan from the Department of Preventive and Social Medicine down in Dunedin. He's an associate professor there, and he's also the co-director of the Social and Behavioural Research Unit. And he's going to talk about spirituality and public health, existing, emerging, or ignored. Kia ora, Richard.
Kia ora, Simon, and kia ora koutou, mihi nui koutou. Thank you for coming along and fantastic talks. Thank you, Rose and Jeannine, and not surprisingly, it was fabulous to see, Jeannine, that tool and the inclusion of spirituality. So I'd just like to acknowledge that. Yeah, so today I'm going to talk about spirituality in the public health context, which it often isn't, and I'll answer my questions at the end. Today my aim is to raise the awareness of spirituality in Wairua within the scope of public health and health promotion, and see how it is a public health issue. I'd like to start with a question that comes from Trevor Hancock, who's one of the godfathers of both public health and health promotion. He says, why do we create a structure, our society, in such a way to create ill health? And is there a way to structure our society as to create health? And it's kind of one of those questions that we think about in health promotion, particularly of how can we create an environment where people can be well, and what might the place of spirituality be in that? And I'd just like to sort of leave that as an underpinning question. If you think about the scope of public health and health promotion, a definition we often use comes from Winslow about this idea of science and art of preventing disease, prolonging life, and promoting health. Health promotion, I'll talk about the Ottawa Charter later. That's our definition of health promotion. And then Fran Baum talks about the new public health, which combines the best of epidemiology and health promotion, and talks about a healthier, kinder world, and one that we can change as people. So that's sort of the scope of public health. If you think about the scope of spirituality, I'd like to present what I call a conceptual framework, and it has these 5 elements. First up is, what is spirituality? It's that ubiquitous question, and we published a paper on this based on hospice work. There's a lot of work in spirituality that happens at end of life, and the key components of this one were around beliefs, values, meaning and purpose, connectedness, identity, awareness, and for some people, spirituality is seen through a religious lens. And notably, we said that this could be understood at an individual or population level, and public health is about population level approaches. The most ubiquitous definition in the spirituality and health literature comes from Pilchowski et al. And it's similar to ours, though it's probably broader. It talks about it being dynamic and intrinsic, including the similar things around meaning and purpose and transcendence, and then through things like self, family, others, nature, beliefs and values, etc. So there are some key definitions that are in the public health and spirituality and health literature. I'm part of an HRC project looking at spirituality and healthcare, which I'll mention briefly later. But Associate Professor Moana Waitoki and Dr. Hukarere Valentine have put together some work on wairua. And they've said this, including and connecting to Māori Marsden's talk about wairua as being the ultimate reality for Māori, and about the inherent sacredness to Māori existence. And I'm very careful to always quote, I guess, Māori experts on this area, but I think it's a very important area to consider, so I want to mention it here. A new area that's been published recently, and this comes from a 2024 article about spirituality as a determinant of health. We published something in a chapter in a book on this, but this was really a major publication, and I guess challenging the public health community to think about spirituality not just as a dimension of health, as I'll mention later, but also as a determinant, which is sort of the causes of the causes. And I think that's something that there's a lot more work to be considered. In terms of the second component is the principles. So how we understand health and whole impacts on how we practice. So we have heard about Te Whare Tapa Whā already, Kia ora Mason Jury, the hospice framework uses that's a similar model. The Whānau Whāle and many of the other Pacific models use this, and then there's this one's from oncology in the Netherlands. All of them containing spirituality as domain, a dimension, a component of it. So that has a huge impact on how we understand health. In terms of the evidence, there's a growing body of evidence. In fact, there's 70,000 plus peer-reviewed publications on spirituality, religion, and health outcomes. And one of the best ones came from this excellent article in JAMA, the Journal of the American Medical Association, a very high-impact journal. And the key things here are that spirituality is important to most people with serious illness. In fact, in our New Zealand national study, we found that 69% of people at end of life wanted spiritual care. So it's frequently desired, it influences decision-making. However, it's frequently unaddressed. So this was a review article across the world in 2022, and it is associated with better health outcomes. So the research is suggesting, and here's a whole lot of areas which I won't go through. I just wanted to show you that there's many areas that have had study in spirituality, that it has an impact. So when spiritual care is considered, it has an impact on these areas. The Canadian study was an interesting one. This was another review. Most of these are review articles, but it said that religion and spirituality influence health behaviors. And as a health promoter, I was particularly interested in that because we don't talk about spirituality in the causal pathway in our understanding, in our needs analysis, and our planning for health promotion programs much. The evidence is such that it's now impacting policy. These are a whole range of guidelines. The two on the right are Australia, the left ones in Scotland, New Zealand, and America, and the Ministry of Health guidelines on supportive care and cancer suggest that we should consider spiritual needs of people with cancer. I can tell you this is aspirational. It continues to be aspirational in the recent strategies that came out at the end of the Labour government's term. There was 5 strategies, and almost all of them had something about spirituality. The overall health strategy, the whole order Māori strategy, and the Pacific health strategy, which I particularly like, where it says not only Pacific peoples, but all parts of the health system to value physical, mental, and spiritual well-being. And then there's some surprising places that spirituality comes up in policy. Treasury now has what it calls a he ara waiora framework, and at the center of this framework of well-being is wairua. At the centre of the Health Equality and Safety Commission framework is wairuatanga. And if we think about a good death, which is something that we don't talk enough about in public health, because we all die, we talk about how to prevent death a lot, but actually we're all going to die, and part of our work is thinking about how we can die as well as possible. And this very good work from the Grattan Institute in Australia is talking about the importance of access to spiritual care and emotional support. The fourth component is the zeitgeist, and this is the idea of why are we talking about spirituality now in sort of a postmodern, post-religious age? I think one in New Zealand is because of people like Sir Mason Jury, Halkukati Valentine, etc., about the importance of spirituality. The fact that we now are largely becoming less and less religious. We have this idea of this long dying and what's replacing spirituality. And also there's some interesting work on the dispirited healthcare workforce. And then finally, this concept of the numinous. And this is the idea of spiritual or religious awe-inspiring moments that happen in all sorts of ways, different for different people. There's research on this around blue space, green space, that connection with land, connection with sea, and connection with awe. So if you like, those are the 5 components of the conceptual framework. So that's what we're talking about with spirituality. But if we come back to public health, so this 20 years after the Ottawa Charter, the Bangkok Charter emphasised mental and spiritual well-being as components of health promotion. Oh, sorry, I'm on the wrong slide. This is the public health slide. So the Bangkok Charter, 20 years later, emphasised spiritual well-being. In health promotion in New Zealand, when we talk about it and teach it, we talk about the 2 po of health promotion. One is the Ottawa Charter, the other is Te Tiriti. And of late, there's been more discussion of the wairuatanga or the oral health article, or the oral article of Te Tiriti, which may be understood as honouring and considering spirituality. So I think even within the first 3 articles, the ones we know best, there's an argument that spirituality is a component of those. Then if we think about the Ottawa Charter, I think that there's 5 strands of the Ottawa Charter that many of you will know. I think in each of those strands, we could consider the place of spirituality. In healthy public policy, in many, I've already showed, and there are many examples of spirituality there, but how do we operationalize and develop it? And create and support environments, advocating for environments that allow spiritual flourishing, I think could be part of health promoters' work. In strengthening community action, enabling communities to name their identities, beliefs, values. These are critical components of understanding communities and working with communities. Developing personal skills, thinking about healthy choices. We talk about making healthy choices the easy choice. What about considering spiritual skills and spiritual literacy? About 80% of New Zealanders are not actively religious, and yet they arguably have spiritual needs. So where does that spiritual literacy come from? And then finally, working with our colleagues who get 98% of the health budget, thinking about what about thinking about a whole person-centered approaches, and where does spirituality need to be addressed within a dominant medical model? Mostly in health promotion, we often talk about these 4 things: smoking, alcohol and drug misuse and abuse, nutrition and obesity, and physical activity. And I think quite rightly, we think about these things, considering that they're so important in the causal pathway of things like cancer and heart disease. However, we don't talk much about the place of spirituality, both in the research and in the interventions. So I think spirituality may be a particularly important component in public health research and practice. Without it, we're not seeing the whole picture. We're not understanding perhaps the current and the future terrain, and missing both a determinant and a dimension of well-being. And as many in the literature on spirituality and public health has said, that we're ignoring a lever for societal well-being. Finally, I'd just like to do a plug for a project that we're looking at the moment. This is a big HRC-funded health delivery project. It's a national project where we're looking to understand spiritual care map spiritual care and work with iwi and stakeholders to improve spiritual care into the future for the 21st century. We're doing virtual hui and face-to-face hui and a range of other projects. Love to have your contribution. We've got a website, spiritualwellbeing.nz. It's got a whole lot of information there, and also opportunities for you to have input into this. So finally, spirituality in public health. I asked the question, does it exist? Yes, I think it's inevitably part of our own implicit positioning. Is it emerging? I think yes also. It's increasingly part of our research agenda and practice. Is it ignored? I think unfortunately yes, up until recently, but this is changing. Increasingly it's part of our definitions, our determinants, our evidence, titiriti aspirations, and the zeitgeist. Kia ora.
Kia ora, Richard. Thank you very much for that. It's and thank you for all your acknowledgement. I'd like to just acknowledge our three speakers for their fantastic presentations, showing some of the breadth of what we do in public health across the country. So now we have the Q&A session, and I'd again encourage you, if you've got any questions, to fire them into the Q&A. You can just sneak one in before we close. I'm going to open it up with Rose to start with, and looking at some of the questions we've got here for Rose. So a couple of the questions we're looking at the use of meth in pregnant and lactating women, and what are some of the impacts on children and on children's development from there?
Thank you. That's a really important point, and I'm so glad that people raised it. So the short answer is yes. So methamphetamine use during pregnancy and lactation can have quite significant impacts on the baby. These can include things like preterm birth, low birth weight. There is the potential for a baby to experience withdrawal if use has been heavy in the close kind of lead up to birth, so experience withdrawal symptoms. And it can also have quite significant impacts on brain development and behaviour. So it is a significant issue. Our data on this in New Zealand at a population level is exceedingly poor. So we don't have decent, it's a general comment about our drug use population level data. Actually, it's really bad. The most recent good data set we've got is from 2007, 2008, which is simply not good enough. So it is a problem. It is a significant problem. As to the magnitude of that problem, I can't answer. The important thing I'd like to say, I think, about this is that, to me, that is exactly the issue, the type of issue that reinforces for me the need to take a public health approach. If we think about things like we want women who are pregnant to be able to seek help from their healthcare providers. Why would they do that if they feel like they're going to be stigmatized or shamed or criminalized? So, that whole aspect of stigma reduction becomes really important, because we want people to be seeking help. When they seek help, we want them to have access to appropriate services. We can't tell people, oh yeah, that's great that you're seeking help. Wait 2 months, please, or you're going to need to travel 3 hours, please. Like, we need services that are low barrier to entry and are appropriate for New Zealand and for its context. So it's a super important public health issue, but one that to me really reinforces why a public health approach is so vital.
Awesome, thank you. I'm just going to move on to Jeannine now. I'm going to move it around a bit. So we have a question here. Do you see this tool as being used by primary health care professionals? And if so, would this include primary health clinicians with limited knowledge of te ao Māori or te reo Māori?
Kia ora, good question. I guess what I would hope that over time we would get to is that it would be able to be used by a range of different health professionals, including in that primary care setting, regardless of the health professional, I think that kia tūpato, be careful, do no harm is an important element that we want to be taken with the use of this tool. So thus the training, the identification of some training to be able to use this tool. So that would require, as we're still in the process of developing up what that training might look like and how formal that might be, but knowledge of te ao Māori and te reo Māori would be a requirement of that. I also do, as with one of my other hats, teach hauora Māori to 4th and 5th year medical students, and I would say that the training of medical students and thus our future medical workforce definitely includes some use of te reo and hauora Māori. So I think the workforce is changing, that is coming through. So that would be my response to that question. Kia ora.
Kia ora. Thank you, Jeannine. Now one for Richard, spinning him around. Is the Ministry of Health currently active on operationalising spiritual health across either health promotion to the health system?
I think the short answer is no. There are pockets of it happening. Jeannine gave us a very good example of it happening in research and supportive care for Māori. Māori providers around the country, healthy communities, for example, I know in South Auckland, they use a wairua focused approach. So there's parts that it happens, but there isn't a consistent approach. And I think that's something that still needs to happen. So there's still work to be done.
Kia ora. I'm just going to cycle through again just quickly, a couple more questions. So back to Rose. And I guess in terms of overcoming barriers and how do we factor in those barriers, be it things like gangs or government policy or so on. And also there was another question which kind of along a similar theme, but relating it to current proposed changes on laws around nitrous oxide.
Kia ora. Yeah. So I guess the issue of gangs is an important one, right? And it's a function in part of the fact that we have a black market, right? So if we have a black market in drugs, then that comes with crime and social harm that exists because of our drug policy settings, not necessarily because of that drug per se. So I think it's really important to kind of consider this idea of what some people call legalization, but I think that kind of has connotations that are unhelpful to people. But this idea of regulation, of strict public health, government kind of controlled regulation of a drug as a way of overcoming a black market and gang related crime and harm, because certainly drugs are a significant source of profit for gangs in New Zealand. And there was a question that came in about nitrous oxide and the recent decision that was made to make it harder to get. And it comes back to that same question of what we don't want to do under any circumstances is create a black market in drugs. It is unhelpful to do so, and we lose control of it once there is a black market involved, and it creates more harm. I think I'm very much publicly on record saying that I disagree with the recent changes to the way in which nitrous oxide is being regulated, because it has relatively low amounts of harm, and therefore a harm reduction approach would be far more appropriate, and we could look at ways to try and reduce harm through things like better age controls or not selling the really large canisters, or harm reduction advice to people using it, without taking an approach that is very kind of heavy-handed and has the potential to create a black market and then cause harm. In terms of overcoming barriers, that's the $1 million question, right? Like drugs is just one of those topics that is politically seemingly very scary and intractable, and we have to keep trying through those methods that we talked about, through bringing both values and evidence to bear, and through ongoing dialogue, and through challenging stigma wherever we see it, because change happens very, very slow, but then very fast. And I'm just waiting there for the moment where the change is going to happen very fast.
Thank you, Rose. I was just going to fire one over to Jeannine now regarding the approach that you've suggested and how it may place a lot of expectations on nurses and doctors in public hospitals where there's already a lot of stress with overwork and that.
Kia ora, thanks for that. Good point. I do want to just acknowledge that our health sector is definitely, and there's people obviously who are working in it stretched and stressed, but nonetheless do a pretty amazing job, I think. Although my presentation went through quite quickly, but this tool is particularly developed for use in the community setting, acknowledging that SF34 tool that we built it off was primarily focused in the hospital setting. So we've developed ours more for use in the community setting, where often there's a bit more time to develop relationships. It might take more than one visit, for instance, to work through the tool if someone's in quite a lot of pain, for instance, it might be a priority to actually sort that out in the first instance with that person. So more community focused use of the tool rather than hospital settings. Kia ora.
Kia ora. I just want to squeeze in one more for Richard to keep it all balanced before we wrap it up. And it was again, it was about the hospital context and spirituality support in that, because it's often limited to just from chaplains. So what more how could we do more to professional development for clinical staff?
Well, in the last 5 years, we've been teaching spiritual care in the clinic to medical students. We're now teaching it in second, third, and fourth year. It happens through Hauora Māori as well. I'd like to acknowledge Jeannine and co. So our future doctors will know, one, how to do potentially spiritual care history taking, and the big thing is know how and when to refer on to spiritual care experts, a la chaplains. In connection to that, there was a question about, I love this word, spiritual imperialism. I think that's an important component, that proselytization doesn't happen. I have a whole section in my teaching about the ethics of spiritual care, just like other areas of medicine and health for nurses and doctors, other healthcare professionals. It must be done in beautifully ethical ways, because you're talking about dealing with the essence of a person. So therefore, your own beliefs cannot be projected on people. It's about listening and understanding. Kia ora.
Thank you, Richard. And I just want to, it reminds me really to just thank our panelists for such interesting and a diverse range of topics that they've covered. I think it really captures the idea that public health should challenge us to do better and to challenge the way we think about things already. So I think you've seen some excellent examples of that here today. If this is stoked the fires of interest in you and you want to learn more, we do offer public health courses at the University of Otago. So you can see there, I've put up a quick slide showing that. So we have a range of postgraduate courses available across the country in Christchurch, Dunedin and Wellington. There's a range of papers, and it's a very flexible program that allows you to follow your passion and your interest. It's and you can see here just again some of the range of the things that we do. So follow the link there. Google us. Do we still Google, or is it now? Do we chat GPT or Bing or whatever your verb is to find us on the internet? Google stalk our presenters to find out more about what they do. And again, please show a round of applause, virtual applause for our presenters. And thank you so much for coming along and sharing this time with us. And engaging in what we love to do. Okay, take care everyone, stay safe.